Hi there, I'm Rebecca Shatsky. I am the Breast Medical Oncology Team Leader at UC San Diego and Director of the Inflammatory and Triple-Negative Breast Cancer Program there as well. So today, I'd like to talk about my highlights from this ASCO 2025, which was super exciting as far as the breast cancer realm. I'm also an editorial board member of Breast Cancer Today, and excited to speak with you all. So this was a really big meeting for HER2 positive breast cancer. Everybody was talking about the DESTINY-Breast12 study way before it was presented today. And I think as far as DESTINY-Breast09, just to explain the trial a little bit, so that was trastuzumab deruxtecan in the first-line metastatic HER2 positive setting. And it was for an indefinite amount of treatment with pertuzumab, which we know inhibits dimerization of HER2 and HER3. And so trastuzumab deruxtecan plus pertuzumab was given in an indefinite time frame, so just ongoing until progression of disease. And that was versus the standard of care, which was made from the Cleopatra trial many, many years ago now. That was a taxane plus Herceptin and Perjeta. And that's generally given for about 6 cycles. And then the taxane is dropped and the patient continues maintenance treatment with pertuzumab, trastuzumab alone, plus or minus endocrine therapy. Now, at San Antonio Breast Cancer 2024, we saw the addition of the PATINA trial results, which for the triple positive setting, so those endocrine responsive HER2 positive breast cancers, you could add a CDK4/6 inhibitor, palbociclib, to Herceptin and Perjeta maintenance. And we saw that that over doubled the progression-free survival in that setting. And so I found that trial to be practice changing for my triple positive breast cancer patients. And so what the DESTINY-Breast09 data really highlighted for me, and I think Claudine Isaacs, who's a good friend, really hit it out of the ballpark when she did the discussion for this, is that there are serious global inequities as far as the availability of different therapies, meaning that in the US, our standard of care is we can use T-DXd in the second-line setting based on the DESTINY-Breast03 results, and we have been. There's no question in HER2-positive breast cancer that aside from the PATINA trial in your triple-positive patients, everybody would have access to trastuzumab deruxtecan for HER2-positive disease. Now, if you look at the majority of the patients in DESTINY-Breast09, when it was done, a lot of sites being international, there is not a whole lot of access to trastuzumab deruxtecan. So the crossover there was really minimal outside of the US, which led to some kind of confusing results, I would say. Nobody is going to argue that trastuzumab deruxtecan plus pertuzumab is an excellent combination therapy that is extremely active. But I think what's important here and why it's not immediately practice changing for me is that I think that there is a difficulty as far as quality of life that we really need to think about. HER2 positive breast cancer, there is this proportion of patients that maybe are some of the de novo metastatic patients that could possibly be cured. And so the idea of giving them indefinite, highly toxic therapy with trastuzumab deruxtecan plus pertuzumab, indefinitely is tough for me to swallow for my patients because I always consider their quality of life and the toxicities of therapy. And when you look at DESTINY-Breast09, there were 5 what we call toxic deaths. And that, as an oncologist, is one of the worst things you can encounter. That was from interstitial lung disease primarily, which we know is an issue. The rate in DESTINY-Breast09 was about 12.1% of interstitial lung disease. And when you're talking about patients dying because of the therapy you gave them and not because of their disease, that's a tough pill to swallow for me. And so I'm a little bit more interested in general about the Demeter approach, which is going to be a phase 2 trial. Now that's not randomized, and some may say you're not going to be practice changing because of that idea, because it's a phase 2. But it's going to be trastuzumab deruxtecan for about 6 cycles followed by a maintenance approach. And so what I think is going to be a really amazing, highly active idea is to incorporate all of the recent data. So trastuzumab deruxtecan up front for those really aggressive, especially those who have relapsed within a short period of time from their curative intent treatment. And then dropping that after you've done sort of an induction phase, just like you did in Cleopatra with THP, dropping the taxane, and adding a maintenance phase. So either Herceptin and Perjeta, or incorporating the PATINA trial and adding palbociclib, or at this meeting we also saw ribociclib as a potential option there. So CDK4/6 inhibitor of dealer's choice in your triple positive patients, and looking at quality of life in that component. You know, I like that Claudia and Isaacs highlighted maybe in those patients who are presenting with brain metastasis up front. T-DXd is really known to be super active in that space. The DESTINY-Breast12 trial that was presented at ESMO 2024 really showed the best overall intracranial results we've seen with any therapy. But I don't know that this approach is necessarily the best for all comers. And so I'm waiting for the field to evolve and sort of parse out who I think it's necessary for.